lecture for about 20 minutes. And then these four panelists sitting here, Dr. Hanne Tønnesen, Dr. Louis Coty, Dr. Manuel Santana, and Dr. Wing Wai Wang will give their comments to this speech according to the four perspectives which we have in the speech: the patient's perspective, the staff perspective, the organization perspective, and the community perspective. And then we shall also open for questions from you in the audience. So please think about what you would want to ask. You shall have the possibility at the end. And I'm co-chairing with Professor Joykan Shi. And with that, I'm very honored to be able to introduce our Dr. Vivian Lin, who will give the introductory lecture. Dr. Lin is, I have read your CV, which is impressive a lot, and to make a short version, she is a Vice President of Scientific Affairs at the School of Public Health in La Trobe University in Australia, has a long career on different senior positions in health policy, planning and program development, has been working on the World Bank and the WHO, and has a main interest in political economy, social determinants of health, and evidence-based health policy. And so, please take the seat.
今天早上非常高兴有这个机会来参加这个会议，特别因为我是小学没有念完就离开了台湾，所以从40多年没有来了。那么看到台湾一切的进步，让我非常非常的高兴。Now I'll switch into English and thank the organizers for the opportunity to return to Taiwan, which I really have not spent any time at in over 40 years. And it's a great pleasure to see the changes, particularly the growth of the health-promoting hospitals here. It's an absolutely fantastic development. What I'd like to do this morning is to perhaps take you on my journey, and I'm sure that mine will be complemented by those on the panel, and I look forward to a lively discussion. I'd like to talk a little bit about some of the ideals and the complexities that we have in thinking about evidence-based or evidence-informed health promotion. I want to draw on some case studies of my own experiences to talk about the challenges, but to also think constructively about the ways forward. Now, what we like to do, on the one hand, is to make sure that what we do is evidence-based. That is, we have good evidence, we have the right evidence, that we can, by using them, produce good health outcomes and improve health system performance. But in the health promotion world, we also bring some particular values and principles. We want to support, by definition, support people to take control over their own health. We are focused on a certain set of values in our practice, which is people-centered, which is concerned with equity, which in looking towards sustainable practices and ownership, we want to build capacity. Now, is there a problem? When we come to the discussions about evidence-based health promotion, there are many people who do believe that there is a problem. Because so much of evidence-based medicine is focused on the population norm and translating that into practice. But so much of health promotion is concerned about population variations and how to address different contexts. So there are some challenges in thinking about the evidence side. But there are also some challenges in thinking about the practice side. On the one hand, what we like to do is to adopt existing guidelines, so we're not reinventing the wheel, or adapt them to our particular circumstances. On the other hand, working in health promotion to create ownership and meaning in implementing implementing guidelines often means that those who are implementing need to be developing the guidelines. So how do we reconcile this tension? So if we want to have effective health promotion practices, I think there are two challenges we need to address, and they're not insurmountable. One is understanding what forms of evidence are needed and for whom. And secondly, how do we ensure that the implementation on the ground is actually effective? So like the speakers yesterday talked about in the opening plenary, how do we move from efficacy to effectiveness? So I want to share with you some of my journeys through 4 case studies. In the first 2 case studies, I first came across the question of what evidence should be used to design health promotion when there is no existing research evidence in a particular location of concern. I also want to address the question of what is the range of evidence required for policy intervention and policy decision-making in healthcare. So in the 90s, before the world was talking about evidence-based practice, I was involved with designing one of the very first large-scale national health promotion projects in China, funded by the World Bank. We knew that for a time-limited project to be sustainable, we needed to improve the policy and the institutional environment. We knew that we needed to have a surveillance system in place so we can track the risk factors and whether we were targeting appropriately and making a difference. We knew that we had to really put in a big effort to develop the workforce skills. And we knew that that workforce needed to have practice to develop intervention models that were appropriate. But this is where we came upon our first problem. If there were no work done in health promotion in China, what intervention models do we look to? Most of the literature is English language, developed countries, Western industrialized cultures with universal health coverage, health systems. It is what we often consider to be the best evidence. Is that the right evidence? Or do we look towards Japan, Korea, and other East Asian countries because we knew culturally that would be more applicable? Or do we look, in fact, to Russia, Central and Eastern Europe, because we knew that many of the institutions in China were very similar to those transitional economies? So that was our first challenge. Then we had to think about, well, what does it actually take to implement? What was actually the understanding of health promotion in China? No one had heard of the Ottawa Charter at that time. Was there, in fact, a workforce capable of doing health promotion? How would health promotion be adopted by and absorbed into the range of social institutions, such as hospitals and schools? And were there unique cultural perspectives, such as the relationships within the family and intergenerational relations that needed to be considered? We ultimately decided that coming from a fairly traditional biomedical culture, it was best to start with very focused risk factors and look at what we knew about what worked in a whole range of different countries. But we also knew that at the time, the social institutions in China was very much a cradle-to-grave type of organization that was very concerned with the entire community of relevant population. So a settings approach was actually very appropriate for China. And we created a matrix that allowed people to mix and match between the settings and the risk factors. And we went through very localized pilots. And today, when you see health promotion in China, there are many lessons from that project which have been disseminated. So that was my first attempt to grapple with this issue of evidence and translation. About the same time, I was also involved in some policy development in looking at registration of Chinese medicine practitioners in my country, in Australia, where we undertook a range of research projects looking at the prevalence of usage in the community, the risks and the benefits of Chinese medicine, the nature of the workforce, standards for education, and how the professional organizations operated. There was a lot of debates. The medical doctors, by and large, said, if you register Chinese medicine, you'll be accepting that it is efficacious and there isn't enough research to point to the effectiveness of Chinese medicine. The politicians were looking at a different range of evidence. They said if the consumers were using it, and if there were risks associated with it, and the profession didn't have an agreed educational standard, nor was it capable of self-regulation, then the government had to step in. So a completely different set of evidence informed that set of policy decisions. But there were additional things that we didn't consider that came to light. When we looked at the complaints that then subsequently happened, it turned out that there was a clash of contexts. Many of the Chinese medicine practitioners were trained in specialties within a hospital setting. In Australia, they were practicing in a community setting with consumers who had opted to seek complementary healthcare because they wanted something more than traditional biomedical paradigm. They wanted lifestyle advice, they wanted support, they wanted counseling. And there was a huge miscommunication that happened because of this clash of cultures. And many of the practitioners thought once they were registered, then the government would look after everything, their professional development, their education, and so on, not recognizing there was actually a difference between state regulation and what a professional association would do. So there were these elements of evidence, or evidence about different things, which we neglected to take on board, which became actually quite important in the way that implementation. We continue to have debates about effectiveness, but effectiveness of the regulatory approach, as well as, obviously, the efficacy of Chinese medicine. So here we have a situation where there's a whole range of evidence that might be necessary to look at what consumer preferences are and how the government might intervene in terms of healthcare policy. More recently, I have learned some of these lessons, and I've moved on to doing better. So I want to talk about two other projects where we're looking at integrating evidence from a range of sources, including working across different countries. So IUHP, the International Union for Health Promotion Education, for which I am a Vice President for Scientific Affairs, and Jordan Pelican and David Patterson are both here as members of the Board of Trustees and can talk about it. We're currently involved in a project with the Cochrane collaboration. And what we're trying to do here is to look at what communication interventions are most effective to improve childhood immunization. And we're interested particularly in low and middle income countries. In order to do this project, the first thing we did was to say there are any number of possible interventions. Let's develop a taxonomy by which we can categorize this myriad of interventions so that we can assess the effectiveness of interventions through a Cochrane review. So the process we undertook was we systematically searched the literature, both the published literature and the grey literature. We identified all the interventions, we categorized them according to their intended objectives. We then mapped these interventions onto a previous taxonomy that had been used for communication review. It was one focused on quality use of medicines, and we tried to adapt it for immunization so that we're not reinventing the wheel. And just to check that we've got it right, we undertook consultation, Focus groups, online consultation. We set up an advisory group. We work with people who are practitioners on the ground, who are academic and researchers, and who are also working in international organizations. And here's what happened. Now, the details aren't important, but we started out with 10 taxonomic categories and 34 intervention types. And you could see that we wanted to, or the interventions were about informing, educating, reminding, recalling, supporting behavior change, teaching skills, minimizing risks, improving access, involving consumers, involving the community, and improving healthcare quality. What happened when we actually started to do the consultation is we learned that there were some things which we simply did not find. There were many practitioners who were involved in community-based interventions, and very, very few of these were actually captured in research, particularly high-quality research. Many practitioners believe that the participatory interventions were the most effective. But again, from the literature, there was limited high-quality evidence about this aspect. But instead, there was a lot of literature about mass campaigns. They were researched and researched and researched and implemented, despite the fact that the evidence suggests they are of limited effectiveness. So who was actually driving the program funding was a question that we had to ask. Of course, what we also found that in looking at the literature, the description of the intervention was actually rather simple, so you couldn't really understand what happened. And sometimes the target was on the supply side, sometimes the target was on the demand side, and the objectives often range across knowledge, attitude, behavior, and health status. And it was actually difficult in the literature to actually identify what was the intervention and exactly what it was actually trying to do. So coming out of that process, we went through quite a new taxonomy. It's much simpler. We've gone down to 7 taxonomic categories. But what we have done is to clarify the targets. Many of the interventions are still those, same ones, but we've tried to just shed greater clarity. And you'll see that some of these are the same: inform and educate, remind and recall, teach skills, provide support. But we've also identified some other ones which were more important: facilitating decision-making, enabling communication, and enhancing community ownership. So I think this particular case studies points to, firstly, the importance of combining the published literature, the grey literature, and the consultation at different levels with people practicing in different contexts. And secondly, what we found that by having gone through that process, there was a lot more awareness on the part of the funders about what evidence there was, what evidence was in fact not very good, what additional areas needed research. So hopefully by that process, we will have done a little bit of influence in shaping how they think about the place of research in program funding and program development. Of course, for our project, we've also provided a much better conceptual basis for systematic reviews to be done. And hopefully for research funders, we have also helped identify what were the over and under researched interventions. And we hope to write a paper, do not ever run another RCT on mass campaigns, because we have already too many of those. But we are also wanting to encourage practitioners to document what they actually do, so that that would be a basis for moving forward. The final case study I want to talk about is work we've done with the World Health Organization in the Western Pacific region in looking at people-centered healthcare and what policy measures might be adopted. And this project began with a previous regional director who said, I want to put the heart back into medicine. And we wondered initially, what does he mean? Is it medical ethics? Is it medical education? Is it about psychosocial factors in healthcare? Is it about more responsive services? Is it patient satisfaction? So we began with a scoping study. We undertook systematic review. Always start there. We looked at everything that was part of the Cochrane Consumer and Communications Review Group. We also looked at the evidence for policy and practice and organization, so the EPOC group. And we brought in other narrative reviews to look at specific areas ranging from chronic disease to palliative care, and of course, health-promoting hospitals. We looked for case studies in the region. We developed a systems framework, and then we undertook consultation. We wanted to know whether the evidence was useful, as well as the applicability of the policy measures. We knew that one of the problems we would have is that some people would say, oh, but those Cochrane reviews, that's from industrialized countries, and that's not going to be relevant. And then we knew others would say, but I know this works best in my country, and that is not relevant. So we knew it was very important to take both the published literature and to take under consultations, and we went to 4 quite different health systems: Thailand, Malaysia, Korea, and Bhutan. Now, what we recognized that if we want to achieve people-centered healthcare, we needed to have individuals, obviously, at the center, but they are seeking healthcare in the context of families and community and society. And health practitioners practice in the context of their organizations and the health system. Our reviews pointed to what people-centered healthcare, the characteristics of a system, what kinds of skills and perspectives there needed to be for individuals' families, just as what kind of skills and attributes there needed to be for healthcare practitioners. But we knew that as good as that interaction could be, they needed to be supported by healthcare organizations that were supporting these good practices. And for healthcare organizations to support good practices, they needed to have health systems that provided the right incentives. So from our literature review, we could also identify characteristics of those positive healthcare organizations, as well as the type of health systems that would be important in supporting people-centered healthcare. The literature review also suggested that the patient-level intervention is absolutely essential, but is not sufficient. What worked better was a combination of multiple-level interventions that was more potent than single-level interventions. There was no silver bullet. System approach was necessary. So we suggested there would be 4 domains for policy action. We wanted, firstly, to have better informed and more empowered individuals, families, and communities. Secondly, we needed to make sure that practitioners were not only skilled, but also responsive to the patients and their families. Thirdly, the healthcare organizations had to be more supportive, and the physical facilities were also important. Fourthly, we needed to have better system design, more appropriate rules and incentives. So we proposed a range of policy measures in each of the domains that would, for the patients, improve information sources, patient education, promote self-management and peer support, and also participation. At the practitioner level, to think about the different kinds of education and training, different approaches to education. For the hospitals and other health services, we were concerned about the physical design, the way services were scheduled, the patient journey through that service, the way providers were incentivized, the feedback, the type of leadership that was there, the kind of models of care that existed. And for the health system, we proposed that it would be very important to really develop primary care, to have appropriate purchasing arrangements, to ensure that there were evidence-based service guidelines, good technology assessment, ways to monitor patient satisfaction, be responsive to complaints, and making sure that the system operated in a transparent fashion. This is what we took to the consultation process, and we were very pleased that these concepts and measures were in fact acceptable across different systems and different cultures, which suggests that it is useful, in fact, to go to the international evidence, and it is not just unique in every country. However, we did also encounter skepticism about evidence from Western high-income countries. Interestingly enough, there was more concern to have good evidence about what you did with individuals than evidence about the policy and the organizational measures. And there was a lot of interest in wanting more case studies which were local or from within the region. Again, through this process, we saw there was a great deal of ownership that happened. I was subsequently told by someone in WHO Geneva that when they held the global meeting on compassionate care, all the people from the Western Pacific region kept talking about it's people-centered healthcare, and they were opting for a shared and a different terminology. And of course, this framework, the policy measures were adopted at a regional committee. So it did stand the test of the policymakers. So, drawing from these case studies, and to lead to some of the final points I want to make, I think that when we want to think about effectiveness, firstly we need to think about, well, what's the evidence we have? Was it documented? Is what people do actually documented? Versus what research and evaluation is available. And we think about what is actually funded. We know that there are quite a lot of things that people do which is not research, which is not funded, which is not evaluated. And we also know that what is funded and researched and evaluated is not always published. And we also know what is published is not always easily accessible. So I think we have a challenge in terms of the availability of evidence as we know it. And of course, with the evidence, we have to think about the applicability, the relevance to different populations, health systems, healthcare organizations, social and political institutions. Because we want to make sure that the evidence actually is meaningful. When it's meaningful, people will take it up. Evidence gaps are not random, so we need to do things to fix these evidence gaps. What evidence exists tends to be for simpler interventions with shorter-term outcomes in the developed world. So there are some very big gaps we have to fill. We also have different groups of people who seem to prefer different forms of evidence. So academics, policymakers, and practitioners often gravitate towards different forms of evidence. But we need to bring them together if we want to think about how researchers, policymakers, and practitioners can actually all move in the same direction. But if we have the evidence about efficacy, we also need to move towards effectiveness in implementation. And here is when it's very important to make sure that the infrastructure and the capacity exists for implementation, that there is organizational mandate, there is resources, there is the workforce skills, and I think this will be discussed at another plenary tomorrow. But the missing link that often happens is actually on the monitoring and evaluation side in practice organizations. People are so busy delivering healthcare that there is not the time to reflect and adjust. There's often not a mechanism in place locally in organizations to assess the impact of changed practices and whether those changes in practices lead to better outcomes. So I think this is a critical part of the implementation infrastructure and practice that we need to think about. So moving forward, in terms of knowledge generation, I think we need to do more systematic reviews, but perhaps not only looking at randomized clinical trials, but being able to combine a range of different kinds of research designs so that we can fully represent an intervention construct, enhance external validity, and identify common aspects of interventions. But I think we also need to think about more evaluation of complex interventions, because we need to understand the combination of interventions and context much better. I think we could do a lot more comparative studies, and here that will help us tease out what are systems issues and cultural issues which are local. If we have the end user participation in prioritization of research, then we can be sure that the likelihood of uptake is going to be better. And we can even do better by doing more case studies using common templates so that we start to document the practices and create evidence from practice. But we also need to do more in research translation and exchange. There are interventions which are currently being carried out which has insufficient evidence. We need to get much better evaluation. We also know that we have interventions which are being practiced that produce little effect. We need to substitute them or discontinue them. To do these things, I think we should integrate research and evaluation infrastructure in healthcare institutions better. We want to support implementation better with all the different kinds of mechanisms such as quality assurance, continuing education, clinical pathways. And where people are innovating, we want to ensure that participatory action research is possible in place and to involve the end users. It's a fairly major agenda forward. I think there are a lot of gaps to be filled in both knowledge generation and knowledge exchange. And to support this, the IOHP has now established a global research working group. We are starting to take an inventory of the research resources amongst our members in order to really promote greater attention on health promotion research. We're looking at organizing more research workshops at our conferences, map and analyze the research funding that exists in order to advocate for more attention in this area. And I hope you will all be part of this larger effort. Thank you very much.
Thank you very much, Vivian, for this very important and thought-provoking introduction, which informs us that we must be much more critical thinking about what we know and what we don't know. And I shall now give the word to Hanna Tönnesson to make the first comments and questions to this presentation. And you have the role to take the patient's perspective. Please, Hanna, what are your comments and thoughts to begin?
Thank you very much, and thank you for a very brilliant presentation. It's really good to see that Cochrane collaboration is now also used by health promotion researchers. It's so fantastic. And that will bring us to a new level of research, of knowledge and experience and implementation as well. And all the good advices you have given here would also be possible to see in the Cochrane collaboration handbook, which is about 500 pages or something like that. So it's a huge job. And thank you so much for using this wonderful and well-proven model for health promotion. We definitely need that. when it comes to the patient perspective, it is really, really important to add that to any kind of research. We all know that even if we use the best evidence-based methods for research, the randomized controlled trials, even if we have the best staff competences for implementation, the best cultural and tradition for implementation, the best monitoring for effect and impact, the patient preferences are really, really important. If the patient do not like to have the intervention, do not ask for the intervention is not worth nothing. So we really have to evaluate, to interview, to make qualitative studies together with the patient in order to identify their competences, their wishes, their expectations, and their experiences to further develop what we call best evidence-based practice. That consists of the patient preferences, which is very often forgotten. It also consists of the staff competences, which sometimes are forgotten, and then it exists of the evidence, which is seldom forgotten. So the patient view is really, really important for our future work here. The studies hitherto shows that the patients are very positive for intervention, and the patients are very positive for health promotion. But we have to meet the patients exactly where they are, and we have to follow their traditions, their culture, and their needs and preferences, instead of just bombing from outside saying that this is what we're going to do and you have to eat this tablet or do these changes or act in these conditions. Patient preferences in the future, when we have established evidence and we have educated our staff, would be, I think, one of the missing links in our whole process. So that should be where we would put our focus in the future. Thank you.
Would you want to respond to this? Yeah, or you could respond directly if you would want to respond to this. You don't. Then we take the whole panel first. Yes, thank you. And then Dr. Louis Coté, you have the road to take the staff perspective. What are your comments and thoughts?
Yes, I will. I am not a researcher. I am an administrator, and I will. What we have seen, you know, because we have. I have chaired a working group about what should be effective healthy workplace strategy that we can implement in our HPH network. What we have seen is that a healthy workplace program that will be effective should be consistent with the institution's other orientation. So it should be aligned with the mission of the organization and with the policies and the culture of the organization. Should be supported by the senior management. Should be participatory. So there is a concept, you know, in the Ottawa Charter that it's not only, you know, to improve the health, but the concept of health is related with empowerment and control on our environment and the capacity to answer our own needs. So effective programs generally are participatory. Take into account also the specific health needs of specific group of employees. There is a study, for example, by Aldana that demonstrated that all the workers are not alike in the health organization, and effective program take into account social determinant, social status, if you have a man, a woman, your age, your preferences, your culture. So we do not have to have one size fits all, you know, program. Also, effective program, what we have seen as a multi-strategy approach. So they have activities aimed at creative, positive work environments to raise awareness, activities centered on the acquisition of skills, and also you work to change the work environment and also to support individual change. Also, one of the problems that we have seen, you know, in the studies, often they are measuring short-term effects, but we not see so many studies that are measuring long-term effects of programs of activities. For example, the Aldana study that is a quite well-known study. It's a study that uses, you know, I would say, good research. It's a randomized clinical trial, but they measure after X weeks, after 6 months. So you don't know if the change they have observed, for example, in the weight, the nutrition pattern, behavior, will they sustain over the years? You know? So that's one of the weakness, I would say, when we are make a review of literature. Also, we do not have seen, I would say, enough studies that are measuring the efficacy or the effectiveness of multifaceted program or complex strategies. But we know that if you do not use an integrated strategy, you will not succeed. But we have to have more evidence about what is an effective multifactorial strategy. Yes, I think that's the main points, because the reason why we implement these programs are quite demonstrated in the literature. You know, it's clear that if your employees are healthy, are motivated, are mobilized, you will have reduced absenteeism, you will have a low turnover, you will have a higher productivity, you will attract personnel, and that's a very important issue now because we have a shortage of manpower, and also we have competitors, you know, to attract personnel in other sectors of the economy than the health sector. So we know that if you are an employer of choice, you will have better results. But what we should know better is how we should build an integrated program to succeed.
So thank you, Louis. And Vivian, you still wish to have all questions aboard. So I leave the word to Manuel Santana, who will have questions and comments in the organizational perspective.
Ciao, Anne. Good morning. First of all, I want to present my excuses because my spoken English is not very well, as you can see. And I think this is more work for translators. I agree with what Professor Vivian said, because if we do a bibliographic research in any database, you can see that few bibliographic records exist about this topic that Vivian Lin said. For the reason, it's necessary to do more research, and to do this, it's necessary to increase the collaboration between hospitals and health services and universities. That means between the production process and the research and the teaching process, or between the clinical units and research units. I can tell you an experience about this because we have oriented our work in our regional HPH work in this sense. I am from Europe, from Spain, from Catalonia, from Barcelona, and I'm teaching and I work in a teaching hospital. All that our different work groups have done has the objective in our HPH network. We work with different work groups. In these groups, they work with the objective, with the sense to obtain results that after can be published in a scientific journal. But this needs time, like all scientific research. To obtain results, we need time, and this is for us is a new area of work, of research. But the important thing is to work with this sense. And this is the inspiration of the organization where I work, a clinical hospital, where clinical practice, teaching and research are inseparable. And with this philosophy, we have obtained a lot of scientific evidence in different medical areas. Now it's time to research in health promotion, to demonstrate to the politician also to citizens, the effectiveness of this work in people's health. In the Catalan-speaking world, the first step was to evaluate if the hospitals of our network accomplish the health promotion standards. This is a good method, a very good methodology to begin to work in health promotion. The results of this evaluation permit us to orient our work to improve the standards that we haven't accomplished until now. We did this evaluation in 2009, and now in 2012 we have done a new evaluation to know what is the current situation, and we will continue to do so as long as possible. In conclusion, my suggestion is collaboration, improve the collaboration between clinical units and records units and research units. It's good a leadership, but it's very important a teamwork. For me, teamwork is more strong than a leader. And research to obtain evidence that can help to convince our colleagues and politicians that health promotion is a good option to improve health of the citizens. Thank you.
Thank you, Dr. Manuel Santana. And now we have Dr. Yingwei Wang. Our panelist is over there because he has some pictures he also would want to use. Please, Dr. Wenwei Yang, your comments and questions to our speaker.
Okay, thank you. When I was studying in the United States, my advisor told me that if your English is not good, at least you show the slides. So I use the slide to give some feedback on my experience. So I just go on to sharing some of the experience in Taiwan and also my reflections on the discussion in this morning. Okay. First, we want to share some of the experience in Taiwan. That yesterday we have a presentation, a plenary one, that shows some evidence of the smoking cessation in the other country. But now at least we have some evidence that for smoking cessation rate in Taiwan, there are some intervention. And during this intervention, that there is evidence that the smoking cessation rate is decreased. This is one of the evidence that we are very proud of our intervention. The second is that yesterday we talking about the non-communicable disease (NCD). In Taiwan, we have some evidence that we do some such like the diabetes mellitus integrated delivery system. It starts about 7 years ago, and this program is quite successful as we have some integration between the hospitals, the local governments, the Bureau of Health Promotion. The hospital included the team, included physicians, nurses, and nutritionists, and also the patient is in the center. And also we have the national health insurance, and also we have specialists, and we have the shared care support group. During this integration program, that we show that if they join this program, the other people, the diabetes people, they do not join the program. If they join this program, we find that the testing rate, the patient compliance, adherence to diabetes control is greatly enhanced. And also they follow up the protocol about checking of the fundus, the eye graph, and also doing some of the lab tests for the renal function. And for the result, the outcome of this program, we show that if we join the program, the HbA1c, means the indicator of the diabetes control, is greatly improved. And the pool control group is less in the intervention group. And also we show that the blood pressures and also the dyslipidemia is also improved in the intervention group. So we show that since the year 2005 and then 2010, about 6 years, we noted increased the progression of the control group, intervention group. That means this is a very successful program between the hospitals, the local physicians, the national health insurance, the government, it is a very successful program, and the evidence show that this is the outcome. And in the future, that's because Taiwan is well known for the national health insurance in the world. And now the governments developed a shared care using all this data. And of course, we enumerate the personal information and then provided the data bank from National Health Insurance, from the Rural Health Promotion, and other resources from the government and local research center, and pulling together as a research bank. And in the future, that more evidence for the intervention, more evidence for the treatment will be available from the cooperation between the government, the local academic center, and also researcher. I think in the future, the evidence-based research program will be more and more in Taiwan. And also, yesterday we were talking about social determinant of health. About 4 years ago, that the National Health Research Institute started a program and started for the health people 2 years and 20. And they started this guideline that using the evidence base, and also they try to increase the health life expectancy and also try to decrease the health inequality. And this when planning, there's a lot of protocol, included the policies, included the quality of health care, included the lifestyle and social support environment. And different category included the researcher and also review of the evidence in Taiwan and the world and other countries that we can use as a reference for the future. And also target on the different population, the gender issues, the elderly populations, the indigenous group, and all those people should be, as I read an article about 2 years ago from the Lancet, they're talking about evidence. And they said that the evidence research always focus on certain group in different countries, different population. But if that applies to our population, so we have to review that in the future we have to do some local research on our own country. And how about reflection evidence? There's the Surgeon General said that the tobacco control, for example, is one of the most rational evidence-based policy in medicine, so we need more evidence-based. But he also said, although our knowledge about tobacco control remains imperfect, we know more than enough to act now. That means that sometimes we have to wait for the evidence. Sometimes there's no evidence, but we have to face to target on our project. This sticker is from the CDC from the United States. They said, if you want to be a best practice success program, we need evidence. But before the evidence, we should have a theory framework. Theoretical framework is deep in the evidence. So we have to find that if they find there is some evidence that is successful, what is the theory base? If there's no evidence, then we have to do some theory. The program should be based on some theory. And this is the promotion education. In the year 2000, there's an article that said if the program, if there's after we do the assessment, we should use the theory and practice to apply to our program. So, come back to discuss about the evidence base. This is a research base, but is that research base obviously enough? When I teach my medical student, this is a copy from a textbook from evidence-based medicine. Is that the research method is one part, but the other part is the patient's preference and also the clinical experience. Coming back to the hospitals, we always face with our patient. So there is a free model of inpatient care that I teach my medical student that you should use evidence-based medicine, but you should use ethical-based, the patient preference, or also include the experience-based or the clinical effort experience. Then we come to the decision making, and this is the best practice for taking care of our patient. Thank you.
Very much, Dr. Yin Wei Wang. No, yes. And I now leave the word and the question to my co-chair, Dr. Yo Tang Chi.
in order to have evidence generation and translation, we all understand that data collection is terribly important. We have data and we have information, we have knowledge. A basic problem is the reliability and validity. In order to reach that goal, I think some conceptual framework or terminology is important. Number one, my question is, we already mentioned HPH, but many hospitals, they already have community medicine department or section or division. How to define health promotion, HPH and community medicine? That's what should make it more clear about. Because HPH, the basic question is not the individual patients. The target would be the whole population, I would say. So, terminology, health promotion, HPH, and the community medicine. And other terminologies you mentioned, the efficacy and effectiveness. Efficacy will be based more individually, clinical efficacy. Effectiveness is community approach, community effectiveness. So we now have translation resource search from basic clinic then to community. So is that efficacy is more clinical aspect. Effectiveness is more community basis. And the second question is that how define the population going to approach HPH? So catchment area is terribly important. How have the served people population be defined? But to set the catchment areas very difficult. How the goal will be approached and have a defined population catchment area? You can answer the question. Finally, you mentioned system approach and incentive. Now, in Taiwan, we're going to have second generation health system reform. We emphasize payment system will be the capitation. So, if we adopt capitation, would initiate more HPH to do more catchment area HPH approach. Then we can save money because people become more healthy. Then capitation will be benefit to those providers. So it's that capitation, languages, evidence would do more this kind of work. Thank you.
Thank you. Now, Professor Yin, you have many questions, and I have actually one left for you because I was also fascinated by your systems approach and about your discussion also about how we make systems actually support this development and purchasing. And I was fascinated that we tend to use the word evidence-based medicine, but you use the words evidence-informed purchasing. And I just wanted to have a comment about that later. So please, now, the floor is yours with all the questions.
Thank you very much. I think they've been fantastic inputs from everyone and very interesting set of issues. Perhaps just to start with this issue of evidence-based versus evidence-informed. I think that many people have been concerned, particularly in the public health rather than the clinical medicine side of things, that evidence-based medicine means one size fits all. And that it is everyone has to do the same thing because the RCTs produce this evidence. And there have been also concerns from the policymaker community that there's a range of other evidence that need to be taken on board. So I think the shift in language to evidence-informed is to recognize that we don't necessarily have all the evidence about everything. What we need to do is to be informed by the best evidence available and a range of evidence. So it is a shift in language that tries to open up the thinking to move away from what people might think about as one size fits all. I think many of the comments point to some really significant cultural change issues. that makes it somewhat difficult to move as quickly as we want to. For instance, I think that Professor Tonneson's absolutely right. You've got to understand the patient comes in. But it is not the main task of medical schools to teach doctors, or in fact any other health professionals, to start there. You're often taught, these are the things you have to do. These are the lab tests you look at. This is how you make the decision about treatment. And oftentimes in looking at evidence-based medicine, that is what you get as well. So the challenge of getting healthcare practitioners to understand patient preferences, family preferences, is very important, but not necessarily easy. And it poses a challenge for how we train our healthcare practitioners. I think in the same way that, following from yesterday's MC, Monsieur Cotet, spoke about a participatory environment, a positive working environment, it makes so much sense. Yet, so many managers are driven by the bottom line, producing more for less. And sometimes that takes away from the time you need. They think it's wasting time for people to talk to each other, when in fact it might produce a better outcome. So I think sometimes our concern in management for efficiency detracts from our need to achieve effectiveness. So I think there is a cultural change issue there in management. I think that Dr. Santina also talked about when you try to have to get, the research unit, the clinicians, the health promotion people within one organization, a large, complex teaching hospitals work together, that is also a form of culture change. People are used to working in silos. They have their briefs. There are different cultures and different imperatives. To work in a collaboration fashion is something that we have to work at. And so it needs leadership from the top to really drive that and say, that is how we need to do it. And I think that Dr. Wong provided a beautiful illustration of when there is a system-wide leadership, when you can put all these different pieces together, that you can see change at that individual clinical level. But you can also try and think about how does it relate to all these different parts of the system and to the insurance arrangements. Now, the challenge of health reform, I think, is something that we should all take on board. And this, perhaps, is where theory meets politics. And by that, I mean, we know that there are certain kinds of incentives, such as case payment, DRGs, that will drive towards efficiency. We think in theory that capitation would drive towards cost-effective interventions and prevention. But we need to look more closely at those systems that have had capitation and ask the question, have they really moved to more cost-effective services? Have they really focused on prevention? Or is the politics of resource allocation in the health system that the specialists will always win and the hospitals will always win over community services? So I think it's something that really requires close attention, just as perhaps we should think about in systems that are based on case payment, where there is no catchment for a hospital. Is it possible to devise incentives within those systems to still support prevention and health promotion and more cost-effective community-based services? Because I think the theory is important, but the practice is probably a little bit more complex, and it's a very, very important question.
Now we have a time for interactive discussions, and I will remind the audience that you will very soon have a chance to put questions, so be prepared. But before that, I would want our panelists to, if anybody would want to comment back to Vivian, who would want to start? Hannah?
Thank you very much. Thank you for the answers, of course, and your comments. From the health promoting hospitals point of view, and actually health promoting hospitals and health services point of view, this is not a question of either hospitals catching the money or the communities catching all the money. This is actually a question of collaboration. And I think we have to rethink, reorient our own thinking towards this collaboration and to make patient pathways that goes from the community to the hospitals, family practitioner, back to communities, back and forth, and also remind ourselves that the patients are only patient in a short period. Most of the period they are persons, if I may say that. At least they're not in contact with the health services in any way. But making this kind of a collaboration would be much more the future, because we are the persons to separate it into different elements. We are the persons to say, this is concerning hospital, or politicians are the persons to do that. This concerns hospital, or this concerns community. But it is important that we do not stick to that actually very old-fashioned way of thinking. So we have to think about persons' pathway through the systems, and not only upon community or hospital-based intervention and health promotion.
You were talking about the problem, you know, because some managers think short term, you want to, you said, produce more with less, but on the long run, if you will go out of business, you know, in the market today, because if you look at the importance of the manpower in a business or in a health organization, we know that organizations that have good management of that are healthy organizations, they have very better results, you know, they have less absenteeism, they are more efficient in the long run. The second thing that I am preoccupied with, you know, is related with what we call evidence, informed. For example, in my country, they are talking more and more of introducing case payment, you know, with the RG system, like they are using in other countries. But our physicians, especially the specialists, they are not employed by the hospitals, and they are paid for fee-for-service. And so in countries where they are introduced case payment, for example, in many countries, the specialists are employees by the hospital and they are paid on salary. So when you introduce something without taking into account the whole concept, you can create a problem. And I don't know if there are studies, you know, demonstrating that if you introduce case payment without taking into account the way you are paying doctors, can you create more problems than solutions? But I don't know the answer.
I agree, this is a cultural change, and all cultural change need time. It's a cultural change for our organizations, and this type of change need time, a lot of time, and need our work and our effort. But I want to say reflection about leadership. It's obligatory for me, leadership, to obtain cultural change and to obtain resources in research. But it's necessary to have a teamwork, and I think it's necessary to talk about this topic. Thank you.
about the insurance that I remember last time when Clinton visit Taiwan, last time we have a discussion about how to integrate health promotion and the clinical pathway as one of the process in the DRG. For example, you talk about smoking cessation before surgery, there's evidence that decrease the stay in the recovery room. So in the future, if we integrate such kind of evidence into the clinical pathway and collaborate with the insurance payment, I think that this is a very positive and evidence that the policy will change. For example, so also there's a lot of elderly people, they fall around and should go in, admitted to the hospitals for the total hip replacement. But if there are no health promotion when they discharged from hospitals, they come back again and again, falling on the ground. So during the hospitalization, after the surgery, they have the education and site visit and also education about the fall prevention. So all these evidence that maybe in the future we should integrate into the payment system that I think this is more evidence and payment collaboration and it will support health promoting hospital in the clinical base.
You want to comment?
I think they're all really important points, and I think that the way our system is structured can often divide people, prevent hospitals and community-based services from working together in the way they need to, prevent teams from working when they need to. So I do think that one of the things that we need to think about more is what are the kinds of incentives in the system for there to be greater collaboration, for us to think about the patient journey as a whole, rather than simply an episode in an institution or in a health center. I think that at the moment there's a lot of different experimentation with pay-for-performance. That may be a next step from DRGs or capitation, or how you balance the different kinds of incentives. I think we need a lot more research on this. And I mean we, not them. We need to be there thinking about the kinds of objectives that we have in health promoting hospitals and understanding how the different incentives affect the nature of our work. And I think that does also then take leadership that goes across institutions and go across countries to start to say, here's an agenda that we must focus on, we must give more attention to.
Thank you very much. Now I have the question. Is there anybody out there who has any question? We have 2 microphones. Please raise your hand and raise yourself. In the meantime, I have... Yes, please. Please come on. There is a microphone upstairs.
So I must say, as a cardiologist, I like the way you build exercise into this piece. So, Professor Lin, one of the points that you made about guidelines is that they're not really very specific. So we're into this business of, since we don't know to whom they apply, we assume they apply to everyone. And I would suggest that that may be a problem with the way in which guidelines are written. So right now we're working on a project with the National Heart, Lung, and Blood Institute to rewrite the cardiovascular prevention guidelines, all 5 of them, simultaneously. But one of the tools that we're using is a guideline implementability appraisal tool, the CLIA tool, which allows one to write guidelines in much more specific ways. And I'm wondering if guidelines were written so that they translated better on the effectiveness side, if this would be a partial solution to their use in health promotion.
A terrific advance. I think one of the other issues is how we work with people on the front line to get them to really understand. Because what it means is it actually changes your daily practice routines in some places, and getting habits to change is not the easiest thing. So there's got to be a combination of thinking about the implementability as you write them, as well as thinking about how you actually then get it to happen.
Yeah, actually, one of the domains in CLIA is the issue is if we need to change present attitudes, then building into the guidelines, materials, tools, strategies to work on changing the attitudes of caregivers as well as patients in some cases.
Questions out there? Yeah?
Is it possible? I think we also, in addition to what has been commented upon right now, we also have to consider that changing attitudes and habits are difficult. We all know that from our patients that are going to change their smoking habits, alcohol drinking, physical activity or nutrition habits. But that also comes for ourselves. It is difficult for us as health professionals to change our habits. We are not supermen, any of us, so we will face the same challenges when changing our habits, in, for instance, implementing new guidelines, exactly the same habits that our patients have to change when they are going to learn something more about health and health promotion. And please allow me to say that we have, together with WHO, just published a new textbook with good methods and tools for all health professionals on how to engage in the process of change to support this. And when you are trained in this model, please look in the mirror and see where are yourself, in which stage are you, and what habits and attitudes do you need to change. That is our really challenge.
Thank you, Hannah. And now I think we have one more question up there.
Hello, Chris Morris from Australia. Thank you, Vivian and the panel, for a very thought-provoking presentation. I manage a group of practitioners and we're about to implement guidelines, so I'm really thinking about the effectiveness. I'm really interested in how to get buy-in around documentation, measurement of the effectiveness and how you evaluate this, because these are clinicians that we're trying to get them to change their everyday practice. And my thought may be that we get an independent evaluator in to sort of work with people. I'm just interested in your the panel's thoughts on the sort of measurement and evaluation of changing these practices.
I'm not sure that having an external evaluator is always the best thing, although having an external facilitator for the group to work on what are the appropriate indicators and evaluation methods would, I think, be appropriate. And I'm thinking that one of the problems that people often have is when they think about monitoring and evaluation, they think of it either as, here's a bunch of data we have to report to someone else, and we never know what happens, or, oh, we've got someone coming in and doing a report, and we're all really nervous about what they're going to say. So I think the challenge is how to make monitoring and evaluation part of everyday life, and understanding that monitoring is a social process and not a technical process alone. That is, people need to look at the outcomes, look at the data and say, what does it actually mean for us? And that means creating an internal process to examine the data and to interpret it and to consider it. So this is really quite similar to a lot of quality assurance methods, the PDSA, the audit and feedback type of approaches. And we have had a program in Australia now, initially piloted in the Aboriginal medical services around chronic disease, where there was an audit and feedback process, and you can demonstrate fairly quickly improvements in clinical practice. And when this system was applied to health promotion, one of the things that they found is that there was in fact very little documentation and not a very good basis for program planning. But by actually engaging the staff in looking at the data and what they do, the data improves and the practices improves. So I'd certainly be looking for a much more stronger internal ownership process.
Thank you. Now we are coming towards the closing. We have a comment from Hannah, and I actually have one more question myself. So Hannah, please.
Thank you so much. It is really an important question if external monitoring, accreditation, recognition processes for health promotion would help in any way to produce more health among patients and staff, more health promotion deliveries, or whatever you would like to have as an outcome. And that is actually why the International Network for Health Promoting Hospitals and Health Services has established a randomized controlled trial among hospitals to evaluate if a WHO HPH recognition process really increases the health among patients and staff. And also, of course, if it increases delivery of more health promotion activities. And we have done that in the highest quality design for research, that is the randomized clinical control trial. However, we have also added interviews with the patients in order to get their opinions and experiences, and also with the staff, so that is nested into this randomized design. So we're really looking forward to see the results of that study. If you want to join the study as a department in a hospital, you are very, very welcome to take contact to the International Secretariat, and we will support you and guide you into this new project. So you raise a very important question. We hope to answer it in the future.
Thank you, Hannah. I can see two more persons up there. Oh, do we have two more questions?
Yes. If I can make it very briefly, I actually have two thoughts and comments. This is Tina Chu from City Foundation. And first of all, I thought it was very thorough to put together everything. But one concern that I have is that it would be very important and good to have all these evaluations and make sure everything is evidence-based. But sometimes programs have evaluations too late to have time to make more implementations and adjustments before we can make more difference. And you know, when it comes to the end, the program is already finished, and we started evaluating at the very end. There's not too much we can do at the time. So I think another thing is, to think about ways to be able to implement things and evaluate along the process, so organizations, communities, and everyone can react more quickly to whatever the problem is. That's my first comment. And the second issue that I would like to raise is that I think it's wonderful to have so many representatives and people with different talents and expertise coming to this conference. But thinking about this also brings together another inconvenient truth, and that is that bringing everyone here, I went through the process of calculating the CO2 emission of the flights, and it worked out to be more than 400,000 kilograms of CO2 emission. And it's really a dilemma because I understand that face-to-face contact is so valuable, but at the same time, as we're dealing with climate change, how can we make a difference and impact to make sure that our conference can offset its carbon dioxide emission? And as I thought about it, I
we take the second question immediately, and please brief and then a final comment from you.
Okay, thank you. I'm a clinical psychologist from National Taiwan University Hospital. The question is, patients' emotional experience may interfere with understanding of our information. So should we pay more attention on this kind of counseling to show our concern on their on patient purpose? Thank you.
Now, you have the final comment before the address.
Extremely briefly, I think that oftentimes evaluation is done too early or too late. So often not at the right time. But I think the best time to think about evaluation is actually at the beginning of the program. Because if we actually think about what is it that we're really trying to achieve and how would we know we got there, and we build that into the process, then we might actually make sure we have data along the way that we can look at, and therefore be able to adjust programs as we go, and also get the timing right. And I often find that when we start to think from the back, from the evaluation, it helps with program design. And that includes things like taking the perspective of patients on board in the psychosocial issues, because those are issues that often tend to be forgotten about. And then people say, oh, we don't have the data, we didn't collect it. So that's, I think, evaluation is a way to help bring everything together.
By that, I would want to thank the panel and my co-chair for their important input. And especially, I have the privilege to thank our speaker, Vivian Lin. And we have to walk up to the scene. I actually give you something. Please come.